Good evening, everyone. I'll be your host for the evening. My name is Thomas Duchesne. I'm a researcher in the Goodman Cancer Research Center. And as you know, this forum, this public forum, has been going on for about 5 years now. And it was led and initiated by a researcher from the Goodman Cancer Research Center, Nicole Beauchemin, who was recently passed me that challenge and honor actually to host and facilitate those forums. We hold those forums for several reasons, but one of them is to bring together some of the best researchers, some of the best clinicians that exert and work in Montreal to cure cancer, but also work from the bench to the actual bedside. One thing that's really important to stress about our positioning as researchers in the Goodman Cancer Research Center is that our research in 2018 is not made in silos anymore. It's meant to actually, it was done for like this for longest time, but we do realize now the need for collaboration. So it's really an honor for me to host, as a Goodman Cancer Research Center researcher, such a forum that brings together the best and the brightest of the research community in McGill, in the MUHC, but also elsewhere in Montreal. Tonight we have presentations from two researchers, two excellent researchers who make a difference not only in the clinic but also in their research. And we heard the really important work from Michel Capo-Bianco from Pancreatic Cancer Canada and from Elise Monaghan-Joubert from the MUHC Foundation. Thank you very much for those words. And I just want to stress how important it is to be partners in this grand challenge that is pancreatic cancer. But we'll hear next from Adeline Koudia and next from George Zogopoulos, whom was just introduced. It's important also to keep in mind that these forums also are meant to be to provide you with answers, not only presenting data and the latest in the science and treatment, but also to actually welcome your questions and answer them directly. So at the very end of the session, you'll have the opportunity to ask whichever questions you want. We'll distribute papers during the forum, and you can just write whichever question you want. In the very end, George and Adeline and Elise and Michel, if you want also to join along on the open forum, you can come in front here and we'll answer the questions of the audience. We also have two very courageous people coming in who will actually provide testimony of their experience with pancreatic cancer. Those are beautiful stories, and we're really grateful that you came tonight and presented them. There will be one of those testimonies that will be given in French. I'll translate as much as I can spontaneously. And there will be also another testimony that will be provided in English. So those are Mr. Goran's and Mr. Beauchamp's testimonies. And I heard there's quite a bit of family and support who came tonight, so thank you for coming. It's really generous of you to share your experience and provide hope through your experience here tonight. So thank you very much for coming. Vous êtes tous les bienvenus. Vous êtes tous les bienvenus à poser vos questions en français. On va y répondre. On parle tous très bien français. Si vous avez des choses qui ne sont pas claires au moment des présentations, n'hésitez pas à poser des clarifications. On va y répondre. On peut très bien vous répondre en français aussi. Vous êtes les bienvenus aussi. Voilà. Donc, voici pour la programmation pour ce soir. On a déjà entendu Michel et Élise présenter et on va entendre, à la prochaine étape, on va entendre Adeline Koudia, who is a genetic counselor at, and also research coordinator at the Research Institute of the MUHC, but also exerts works at the Cedars Cancer Center. So, but I hear that George wants to introduce Adeline before she goes on and presents, right? So, George, this is you.
Good evening, everyone, and I apologize that we're getting a little bit of a late start. Adeline and I were in clinic, in all honesty, beforehand. Bonjour tout le monde, bonsoir tout le monde, et je m'excuse que nous sommes un peu en retard. On va faire des présentations dans les deux langues. Je vais présenter en anglais et puis Adeline va présenter en français. Puis on va prendre des questions dans les deux langues. Et je vais inviter Élise puis Michel et Thomas avec notre patient témoin à la fin pour répondre aux questions. So we'll proceed in both languages, and at the end we'll take questions in both languages as well. And if I could ask whoever's manning the lights to dim the lights, I think everybody before me was just didn't mind it, but I think I do. So tonight is not really about telling you about the basic science that I do in my lab at the Goodman Cancer Center. It's about telling you what I learned from the basic science that I do in my lab at the Goodman Cancer Center and how we've married that at the Cedars Cancer Center, and about a partnership that we've put together with Michel and Pancreatic Cancer Canada, the MUHC, the Cedars Cancer Center, and the Goodman. I mean, all of this did start at the Goodman and has expanded to the RI and the Cedars Cancer Center as the Royal Victoria Hospital moved over to the Glen site. But the footprints of all of this was at the Goodman Cancer Center. So I'm quite proud to wear both hats and not forget my roots, and we still have an active enterprise there. So I think there is hope. So Michel, despite the fact that I saw 5 new patients today, none of which I thought were appropriate for an upfront resection, an upfront surgery, I think there is hope. And I hope by the end of the evening, by sharing the experience, what we have built, not alone, but collaboratively, both within Canada and these boundaries of collaboration extend beyond Canada and overseas and south of the border, that we have some hope. And that hope may not necessarily be with an answer, with a cure, with a medicine, but that hope, I hope to convince you, is how we've decided to center the care of patients. So here's a disclosure. Disclosure is I'm a surgeon, and I don't want you to hold it against me. Surgery has been perfected to some extent. Surgery can be done safely in 2018, 2019, but it does not provide the answer. In most cases, surgery is not curative. We know that you need chemotherapy with surgery to provide the patient a chance of cure. And the far majority of the time, the patients present with advanced enough disease that we cannot offer surgery to the patient up front, and we're becoming to understand that more and more. And that goes back to the 5 new patients I saw today, none of which I thought should go ahead and have surgery, because we wanted to understand their disease and try to give them a real meaningful chance of cure rather than going ahead to surgery. So why is that? This is a slide that was shared, that was given to me. I haven't seen a tumor of 1.5 centimeters. It's in the middle of it. I can't see where the pointer is, but I'm not sure the pointer will work. But right around those arrows, there's a small pancreas cancer that's about 1 centimeter to 1.5 centimeters. And one would think that if a patient presents with that small of a tumor, that tumor is probably curative. So this patient underwent what's called a Whipple's, or a pancreatic duodenectomy, and the final pathology had node-positive disease. So the tumor had already spread to the lymph nodes. That tells us something about the biology. So it goes back to my disclosure. I'm a surgeon, and don't hold it against me. Surgery alone won't cure. Because even at its earliest presentation, in this patient, the tumor was located exactly where it needed to be, that at 1 centimeter, 1.5 centimeters would cause the patient to become jaundice, yellow, and present to his doctor where the diagnosis is made. But even at that very early stage, the tumor had already presented at a point where there was spread, and we needed chemotherapy. So the question becomes, how do we select that chemotherapy that's right for that patient? So why does this cancer spread so early at diagnosis? Well, for many years, we thought that it follows the development of pancreas cancer, the birth of pancreas cancer follows a stepwise progression model. So you get one mutation in one gene, maybe 6 months later you get another mutation, then you stop, and a few years later you get another mutation. Over time, over a decade, the there's enough mutations, changes in the genes, and the cancer cell has formed, and that cancer cell now has the potential to spread and become really ugly. What we learned in 2016, this is work led by, in this collaborative group, this was before the PANC-1, this is the work that we did that led to PANC-1. It was led by somebody by the name of Fayez Noda, who's now he was at the time a research fellow, and he's now has his own lab at the OICR in Toronto. He made interesting observations through some of the sequencing work that we were doing, that in this cancer, in at least some patients, cancer develops essentially overnight. On the top there, and I can't seem to make this work, but on the top there, what you have is a stepwise progression. You can see there's a bunch of little circles that show cells that get mutations and eventually get a cancer cell. On the bottom is Fayez's unique contribution to science. He showed that you have a normal cell, and that normal cell one night wakes up and says that it will shatter, all of its DNA will shatter, and it will become very malignant. And that probably explains why this disease, in at least a good fraction of patients, presents with spread. So that's why we think this happens. So the other important part that comes up in clinic when I see patients is, what are the treatment goals? And I'm sorry, some of the slide didn't project properly, but nonetheless, what are the treatment goals? So when a patient presents with a very early stage, the treatment goal is cure. And that's where we want to be. We want to be at cure. If a patient presents at a very advanced stage, the treatment goal is to support the patient, improve the patient's quality of life, make sure that the family feels supported. And the way we do this, you don't need DNA to do this. You don't need DNA to figure this out, and you probably don't even need a CT scan to figure it out. You could tell based on the patient's symptoms most of the time. At the very early stage, the patient has a high energy level, their activity is good, they're going on about life. At the very late stage, the patient has a low level of activity. They are having a hard time maintaining, and we have to address that and make sure that we take away the pain and suffering, and we give them whatever life they have, a quality of life. And here's that magic area where the majority of patients are, and that's the stage where there's advanced stage. So the cancer is advanced enough that we cannot operate on the patient and try to give them a chance of cure, but their symptoms are not terrible. They have a good level of energy, which tends to improve with therapy. And I think you'll hear more about that as the night goes on, as some of our courageous people come up and give you a testimony. And that's the stage where we try to control the disease. And that's where I think with this disease, this is where we need to invest, and this is where PCC has invested, and that's trying to understand how do we get the right therapy to the right patient and prolong their life with equality. So control the disease. Take this killer and make it a chronic disease. So I think that's a reasonable goal. The idea of curing every patient is probably not a reasonable goal. So with that in mind, how do we approach this was not put together by me. I have no talent of such with PowerPoint, but it was done by Yifan Wang, who's a terrific resident and graduate student in my lab. And what the figure is trying to depict is, in the middle we have the patient. The patient comes with the family and friends. And there's an adaptation. The patient has to adapt to a new diagnosis. It's life-changing. It's life-changing to be told that you have a pancreatic cancer diagnosis. There's questions, there's uncertainty, there are symptoms that we need to address. And so how do we do this? We try to build a circle of care around the patient. On one end, you have oncology, you have surgery that work together. Supportive care, not palliative care, but supportive care. Supportive care helps manage the symptoms, emotional symptoms included in the symptoms, and helping patients adopt. A pivot nurse is really a nurse navigator. In the rest of the country, they call nurse navigators. And one of the fortunate things we have in Quebec in oncology, we have these pivot nurses that help patients navigate the system. We need more of them, but we go on and we say that Quebec does not provide. This is one area that Quebec has taken the leadership in the country in providing these pivot oncology nurses. So that's what the Cancer Center has done. That's what the MUHC, the Cedars Cancer Center, and parallel programs exist elsewhere at other big cancer centers in the province and in the country. Where we have come in is at the level of innovation. And what we're going to talk about tonight is a certain innovation that we introduced, and there are many more innovations at the hospital around pancreatic cancer care, including clinical trials. And the innovation that we've tried to bring in is this concept of precision oncology. So personalized medicine, every patient should receive personalized medicine, and every patient we try to deliver personalized medicine to. The concept of precision oncology is one that has grown over time, and it is one that we've tried to introduce in the system. And we've done this two ways. One, by bringing a genetic counselor into the clinic, recognizing that patients with a pancreas cancer diagnosis need to go on and have their treatment, and a referral to a geneticist, a medical geneticist, to address genetic counseling issues and doing genetic testing is probably not going to happen because the patient and family get busy with their diagnosis and their treatment for pancreas cancer. So if we bring the genetic counselor to clinic, we're more likely to reach these patients and provide that opportunity for patients. And with it, there's research opportunities that come where we could learn and understand this disease. And the other part, so Adeline is going to speak to you about introduction of genetic counseling and what we do to survey and try to catch pancreas cancer in early stage. And then I will come back and spend a few minutes and tell you about our precision oncology program, which is profiling the tumors of patients in that sort of intermediate stage,